Welcome to Brain Ponderings, your window into neuroscience research, conversations with scientists at the forefront of neuroscience research. And today we're going to have a little mixture of neuroscience and oncoscience, which is study of tumors or cancer. And my guest today is an expert in both, and he studies the interactions of neurons with tumors. So my guest is Professor Hubert Hondermarck. He's a professor in the School of Biomedical Sciences and Pharmacy at the University of Newcastle, down in New South Wales, Australia. And he has an interesting background, which I'd like him to talk about to begin with. So welcome.
Thank you, Mark. Yeah, my background is actually in biochemistry. I was initially trained in biochemistry in France at the University of Lille, north of France. And then I moved to developmental neurobiology. So I wanted to do some biochemistry in the nervous system, which I was fascinated with. And I work on the development of the brain and the activity of various neurotrophic growth factors like NGF, nerve growth factor. And then I moved to the US for a postdoc. I worked with Professor Ralph Bradshaw at the University of California, Irvine on neurotrophic growth factors and their impact on the development of the brain. This is what I really wanted to study. But then I also looked for a position, a more stable position, and I found one in France, back to France. So I came back to France on a university position, and the laboratory had to work on cancer. So my project had to be on cancer. I was paid to work on cancer. This is how I came to oncology or oncoscience, as you named it. And then, well, I will tell you more about that story, but basically what we found is I started to work on cancer cells, and the growth factors that could stimulate the growth of cancer cells. I was looking basically for a negative control in my experiments, a growth factor that I could add to cancer cells and that would produce no effect on the cells. And because I work on NGF, nerve growth factors, and all the neurotrophic growth factors, I thought they were perfect negative control. And they turn out to be more potent than the other growth factors like FGF, fibroblast growth factor, or insulin-like growth factors, etc. And this is how I got into this field of cancer neuroscience, which didn't exist at the time, but this is how we started to work on this. And along that way, I had my laboratory in France, and well, we were showing that those neurotrophic growth factors had impact. They could stimulate the growth and metastasis of cancer cells. But I was interested with something else in reality. That was the possibility for cancer cells to attract nerves in the tumor microenvironment. After all, maybe we thought that maybe if cancer cells were making NGF, it was with the purpose of attracting nerves in the tumor microenvironment. And I looked for money to do this, applied to grants to do that, and never worked. And at some point, I decided to just go somewhere else where I could start from scratch. And this is how I ended up in Australia. Actually, I applied.
And Hubert, so at that stage, people knew then that tumors tend to have a lot of nerves kind of interdigitating in them, or didn't they? But that hadn't really been studied at all, I guess, right?
Yeah, absolutely. So the presence of nerves in the tumor, and we call it the tumor microenvironment. Yeah. The presence of nerves in the tumor microenvironment was already known. But what was thought before is that those nerves were actually trapped by the tumors. As the tumor would grow, the nerves would be surrounded by cancer cells, and there is a process called perineural invasion, PNI, and it was thought that the nerves didn't grow into the tumor, but just they were surrounded by cancer cells. And it was also thought that the nervous system was a bystander in cancer progression. That yes, cancer nerves could be invaded by cancer cells, but anyway, the nervous system did not participate in the growth of the tumor. That was the idea at that time. Yeah. And this has completely changed now.
Yeah. And okay, so then, and then did you do experiments showing that if you kind of put in the same culture dish cancer cells and neurons, that the neurons would grow towards them? Is that how you first started looking at this, or did you start with in vivo in living animals?
No, we started in cell cultures.
Yeah.
Indeed. So you can grow cancer cells together with neurons.
Yeah.
And when you do this, you do realize that the presence of cancer cells does induce the outgrowth of neurites. The neurons just are stimulated to grow in presence of cancer cells. Mm-hmm. And vice versa. The cancer cells in presence of neurons grow faster. So there is actually a sort of amplifying loop there, where one stimulates the other and vice versa. And the way it works is that cancer cells makes NGF, nerve growth factors, or BDNF, brain-derived neurotrophic factors, all those molecules that you would expect related to the nervous system. And that does attract nerves into the tumor microenvironment. The nerves ending in particular, the nerve endings. And once they are in the tumor microenvironment, they do what nerves know what to do, is to release neurotransmitters. And those neurotransmitters then stimulate neurotransmitter receptors at the surface of cancer cells. Not only cancer cells, endothelial cells. So we now understand that tumor angiogenesis, the outgrowth of new blood vessels in the tumor microenvironment, is also controlled by neurotransmitters liberated by nerves in the tumors.
So in peripheral neurons, like whatever, liver, colon, whatever, so it can be sensory nerves that convey pain or touch or whatever, but it could also be part of, say, autonomic nervous system, and so I mean, we could talk about. So in case of pain, right? Cancer patients often have a lot of pain associated, not only with cancer, but maybe with the treatments. So is there a role for the trophic factors in like pain in cancer? Well, there probably is, but is that because the cancer cells are secreting the growth factors and then you get sprouting and kind of increased pain sensitivity?
Yeah, there are different types of nerves you can find in the tumors. Yeah. You mentioned sensory nerves, and indeed they are there. So it means that sensory nerves have grown into the tumor microenvironment. But you also find a lot of autonomic nerves, sympathetic nerves in particular, a little bit of parasympathetic nerves as well, but most human tumors are innervated with sympathetic nerves. So in terms of cancer pain, yes, indeed, it does participate in cancer pain. And you know, by the way, in the adult, neurotrophic growth factors like NGF have a role in pain sensation. Yeah. A crucial role in pain sensation. So yeah, it's a growing area, but we probably have here a way to target tumor growth as well as tumor pain, tumor-associated pain, actually. So we could have a double-edged sort of therapeutic approach where we would target cancer cells by targeting neurotrophic growth factors, but also limit cancer pain. Yeah, that's the objective.
Okay, and so you mentioned neurotransmitters. So you mentioned like 3 different types of nerves: it's sensory, sympathetic, and parasympathetic. So there you're talking about glutamate, norepinephrine, and acetylcholine. Is that right?
Yeah. In prostate cancer, if we take the example of prostate cancer, it's been shown that norepinephrine and acetylcholine participate in tumor growth. So apparently in prostate cancer, during the early phase of tumor growth, the tumor development, it's norepinephrine. So sympathetic nerves are involved, and that stimulates the multiplication of cancer cells. And in later phases of tumor development, when the tumors start to disseminate, apparently it's acetylcholine that stimulates the dissemination of prostate cancer cells. So you see, when you think about it, the old good acetylcholine that we all know as a neurotransmitter for the neuromuscular connection, it's also involved in cancer progression, and in particular in the dissemination of cancer cells in late phase of prostate cancer.
So metastasis, the
Metastasis, yeah.
migration. Okay, so the cancer cells have receptors for norepinephrine and acetylcholine. Their activation of norepinephrine receptors there's some classic that you and I and most neuroscientists know about, we call second messengers. So that norepinephrine will increase cyclic AMP levels in the cells, and acetylcholine will, well, it does a couple of things, but it will, through muscarinic receptors, which I'm assuming are mediating this, it will activate protein kinase C and cause calcium release. So anyway, was there a lot already known about those second messengers and their role in cancer cell proliferation or metastasis?
There are things which are already known.
Yeah.
In particular, the fact that the receptors are the same, and basically the signaling pathways are the same too.
Yeah.
So what you just described in neurons will also apply in cancer cells. So cancer cells have all the entire machinery in terms of receptors and signaling pathways that neurons have. And instead of ending up with neurons growing up, which is the effect of those molecules in the nervous system, you end up with cancer cells multiplying and migrating. But the machinery, the intracellular signaling pathways are the same indeed. And something we can add is that it's not only in cancer cells themselves, it's also in the cells of the tumor microenvironment, the stromal cells, as we call them, endothelial cells, fibroblasts, but also importantly, immune cells. All those cells also have receptors for neurotransmitters, you know. And interestingly, this has been known for a very long time. The literature describing the presence of neurotransmitter receptors in immune cells, in cancer cells, has been there forever. But it was really underestimated in cancer because the reasoning was, well, yes, cancer cells, immune cells, endothelial cells, they all express neurotransmitter receptors. But when you look at the level of circulating neurotransmitters in the blood, there is very little.
Right. And
therefore, the common reasoning was to say, yes, they do express the receptors, but there is not enough ligand. So they probably have no physiological function. But what was misunderstood was what was severely underestimated is that actually, because the nerves get into the tumor microenvironment, they liberate those neurotransmitters in the close proximity of cancer cells and stromal cells. And therefore, in that tumor microenvironment, the concentration in neurotransmitters is actually high. And this has been shown.
So it seems to me then there's a lot of obvious potential treatments where you could kill the neurons that are innervating the tumor, anesthetize them. Both neurotransmitters and a lot of, at least in neurons, trophic factors, they're released in an activity-dependent manner. So when the neuron fires, they're released. And so Are you working in vivo now? You do a lot of in vivo work in where you like implant a tumor in an animal and then try to manipulate the nerve cell, either the innervation or let them be innervated, and then see if you can like slow the growth of the tumor by, some of the things that I mentioned or others.
Yes, absolutely. So we do that too. It is feasible and we do it.
Yeah.
So when you work in animal models for cancer, and it's essentially mice in reality. So you implant cancer cells into the mice, or you induce the growth of tumors, of natural tumors in the mice. You can see also that those tumors get innervated by new nerves growing into them. And you can play, if you inhibit innervation, and there are several ways of doing it. I could comment on this. If you inhibit innervation, you limit the tumor growth. It's even more than tumor growth, interestingly. It's also tumor initiation. So we are not talking here only about tumor progression, but also about tumor initiation.
So spontaneous tumors, as the name implies, you don't know if and exactly when during the life course of a mouse a tumor is going to arise. So how do you go about?
Well, actually, we have animal models where we are able to induce tumors when we want. And so you have models, for instance, of spontaneous gastric tumors. And you know that at a certain age, the mice will all develop gastric tumors. Then you can denervate the stomach and see the impact on tumor initiation. That's the way. And the way to do this is you can use surgery. So you can cut the nerves around the organ. It's not easy to do because, you have many entries for nerves, different levels of the spinal cord innervate the same organ. But surgery is one way. In experimental models, I'm talking about experimental models. Surgery is one way. Then you can use neurotoxic drugs like 6-hydroxydopamine, for instance. That's going to kill specifically some neurons, more or less specifically some neurons. But the way we prefer to do it, and this is what we do in my laboratory, is actually to target neurotrophic growth factors. Because by targeting neurotrophic growth factors, you prevent the new innervation of the tumor, but you don't affect the existing innervation, which is physiologically important. And I think the same is probably going to apply in patients when we will be able to translate that into clinical practice, because surgical denervation is probably not an option in cancer, because if you denervate, the function of the organs you denervate is going to be affected, particularly when we are talking about the autonomic nervous system, because sympathetic, parasympathetic nerves control the function of most of the glands and organs in the body. So denervation is going to have a lot of side effects that are not going to be making the approach translatable. Neurotoxic drugs, the same. You don't want to affect your cognitive ability or your motricity or sensation if you target.
Well, unless you injected them into the tumor.
Yeah, unless you inject them into the tumor. But still, the toxicity, I imagine, I don't know. I doubt about it, but why not? But in our opinion, the best way will be to target neurotrophic growth factors, because then the existing nerves, existing nerves do not need neurotrophic growth factors anymore to maintain themselves. The connections are established and they are okay. So, for instance, massive injection of antibodies against NGF, nerve growth factor, in the mice has been shown to have very little side effects. It's only a loss of sensation in the extremities that you have, and it's completely reversible when you do that. And in animal models, if you inject massive quantity of antibodies against NGF, you decrease tumor growth in a lot of tumor types, breast cancer, prostate cancer, for instance.
Have these nerve growth factor antibodies been used in humans?
Yeah.
Yeah.
Tested in humans. Oh, well, they are already in clinical use, actually. If you think about a drug called, I think it's tanezumab, it's an antibody against NGF, and it's used in arthritic pain because of this
Yeah.
anti-pain
Yeah.
effect you mentioned before.
Yeah.
So such a drugs could be repurposed for cancer treatment.
Yeah. And so you're
There is actually a whole range of neuropsychiatric drugs that are used for different things in neuroscience. They could potentially be repurposed in cancer research.
yeah,
And there are research activities in this area. Yeah.
and are there any clinical trials planned for NGF in cancers in humans?
Yeah, they are already underway.
Ah, okay.
They are already underway. In terms of, I mean, translating that cancer neuroscience knowledge into clinical trials. So targeting NGF, targeting BDNF, brain-derived neurotrophic factors, is also something that looks promising. So there are already clinical trials. But the biggest sector, if I can use this word, the biggest activity at this stage is the repurposing of beta blockers for cancer treatment.
Mm.
Because, beta blockers target the beta adrenergic receptors, and it's the signaling pathways used by sympathetic nerves and noradrenaline. And they are several dozens of clinical trials underway in the world to use them in combination with regular treatments.
So beta blockers have been used for many, many decades, right? For what? Hypertension and maybe some
hypertension, anxiety, stage anxiety, for instance, they are an indication of beta blockers, but it's mainly for hypertension and cardiovascular disease. Yeah.
And is there enough people? Again, yeah, there should be epidemiological data to suggest that people who take beta blockers for whatever years and years and years are less likely to get certain types of cancer?
Well, there are already such epidemiological data. What has been shown, but I should say there is still a controversy about this. So some studies have shown that, among the people who take beta blockers, once they have cancer, they do better with their cancer.
Ah.
They survive better.
Okay.
So this has been shown in breast cancer, prostate cancer, ovarian cancer. Now it is a bit, it's not completely clear because some studies show that there is no impact also of beta blockers. And probably, I suspect, and this is the generally admitted hypothesis, that it's a question of what beta blockers, because there are many different beta blockers. The initial molecule was propranolol, which has a large spectrum of activity, inhibiting different beta adrenergic receptors. But now you have other beta blockers, which have been used for many years, are more specific of beta 2 or subtypes of beta adrenergic receptors. So the studies some studies are very conclusive about the beneficial effect of beta blockers in cancer. Others are not. And you have, of course, also some studies suggesting it could be detrimental. So I think we need to be very careful with this now. And it's probably a question of which beta blockers and which cancer too.
Yeah. And going back to the NGF antibody, so if they're given, intravenously, do they, well, I guess they can, so in the fine blood vessels, right? So they get into the capillaries and then somehow they get outside the blood vessel and then bind to NGF there, right?
Yeah.
Is that the idea?
Yes, absolutely. But remember something when we talk about antibodies against neurotrophic growth factors. It's not necessarily the full length antibody. You can have short parts
Yeah,
recognizing. So it's just like if you know about this drug in cancer called Herceptin or tanezumab, it's an antibody against HER2,
yeah,
the tyrosine kinase membrane receptor. But it's not the full molecule, the full antibody. It's more or less the part of the antibody that do recognize the HER2 has
yeah,
been engineered so that that molecule can nevertheless diffuse in tissues.
yeah.
Because I suspect where you were going was where is that going to get into the tissues and block NGF.
Right.
So because it's smaller than a regular antibody, that's one
Okay.
thing.
Okay. Um, then let's see. What about the brain, right? So there's uh, glioblastoma, glioma, neuroblastoma. And by the way, I think most people know this, but cancer cells come from cells that are proliferative, right? As far as we know, neurons, once they become neurons, don't form cancer cells, or senescent cells probably don't either. I had a podcast on senescence with uh, Darren Baker at the Mayo Clinic, who's been doing a lot of work on cell senescence in the brain and cancer. So what about in the brain? I mean, there are the same neurotransmitters, the same neurotrophic factors. So the assumption is it's similar, or do you think there's differences between brain tumors and peripheral tumors in terms of the interaction of neurons with the cancer cells?
Well, I think that when cancer happens in the brain, then it's the neuronal stimulating effect, the stimulating effect of neurons is maximal
Yeah,
because those cancer cells are trapped, surrounded by billions of neurons.
yeah,
So this is really fueling the tumor. And my personal interpretation of this is probably why brain cancer is so devastating, so
yeah.
terrible as a cancer, because the stimulus. If you think about prostate cancer, you have a few neurons. I mean, many,
Relatively,
but
yeah, yeah,
relatively low
yeah,
number of neurons associated to cancer cells. In the brain, it's massive. This probably accounts to the fact that brain tumors are difficult to treat because even if you kill cancer cells, most of cancer cells with radiotherapy or chemotherapy, the remaining one are going to be stimulated by the surrounding neurons
yeah,
anyway. And unlike in prostate cancer or in breast cancer or lung cancer, you can't kill all neurons around because we need the brain.
yeah,
So that's the situation. Now, the most dangerous form of brain cancer is glioblastoma, gliomas in general, but in particular glioblastoma because it's the higher grade. And in glioblastoma, it's been shown that the cancer cells actually hijack synaptic connections in the brain. So cancer cells stick to the synapses and use the neurotransmitters like glutamate that are used there for their own benefit, for their own growth. So it looks almost like a synapse between cancer cells and neurons. It's not exactly a synapse, but it's the cancer cells stick around the connections, and they really use those neurotransmitters. Yeah.
You mentioned that, and this is well known, that you treat a cancer patient with chemotherapy or radiation or a combination, and oftentimes, and this is seen with glioblastoma too, the tumor will shrink, right? You do the MRI imaging and you see it's smaller, but then you get recurrence, and you mentioned there's these resistant cells. And I guess I don't know exactly when, but at least a decade, or maybe it's quite a bit more than that. A couple decades ago, there's this notion of cancer stem cells that within a tumor, there's a probably relatively small population of what are called cancer stem cells that have different properties in some respects to the rest of the tumor cells. And so do you know about the relative, one might think maybe there's differences in the way cancer stem cells and I guess what do you call the rest of the cells, that the rest of the cells in the cancer cells in the tumor interact with neurons? Is there any work going on there, try to dissect out, interactions of nerve cells with cancer stem cells versus cancer parenchyma or whatever the terminology is?
Yeah.
Yeah.
Absolutely. That type of research is going on. It's not easy in the brain because, in the brain, most neurons are differentiated.
Yeah.
And you still have neuroprecursors around, so you still have stem cells around. But their number is low compared to the total number of neurons. So the brain is a difficult model to study your question. We know that there is cancer stem cells in the brain for sure. The way to find out their participation in the tumor, in the growth of the tumor, in particular in relation to neurons, is more difficult to study in the brain because of that number. But in other models, if you think about gastric cancer, or even in basocellular skin cancer, it's been shown that there seems to be a particular connection. The nerves in the environment of the tissue, the normal tissue in the stomach or in the skin, a lot of those nerves endings are around the places where you find stem cells. So there seems to be a particular connection between neurons, nerves, and stem cells themselves. Very clearly shown in the skin and in the stomach. So you could imagine the same in the brain too, absolutely. What has been shown in the brain, and it's interesting, is the neuronal activity may have an impact as well. So it's not only the presence of nerves that seems to be important, of neurons, if we are talking about the brain, the presence of neurons, because they liberate those neurotransmitters. But if the neurons are very active, apparently it's facilitating tumor growth. And I could tell you, this has not been done by my lab, but a group has published, I think it was last year, an interesting study where they investigated the tumor in the olfactory bulb of the brain, and they modified the ability of the mice, it was done in mice, to smell. Okay, and you can block the right nostril or you can block the left nostril in those mice. And those mice were spontaneous model of brain development, brain cancer development. And they could show that if you block one nostril or the other, you're going to increase the number of tumors in one side or the other of the blood. Yes, so neuronal activity is apparently very important.
So if you have a tumor in, and I'm going back to Hubel and Wiesel and the visual system, right? So the information from our right visual field ends up in the left side of our brain. So then if you have a tumor in your left occipital cortex, then you would want to wear glasses that block vision. And that's kind of the idea?
Well, we are talking about it. Yes, absolutely. This is in the air. So some experimental protocols are testing this now. Yes, absolutely. If you reduce the neuronal activity, like for instance, blocking the visual area or with smelling, or depending on the part of the brain where the tumor is, you could reduce tumor progression. Absolutely.
One thing
I mean, it needs to be clearly demonstrated in clinical trials, huh? But in experimental animal models, it works.
yeah, when others have done a lot of work on calorie restriction, intermittent fasting, ketones, ketogenic diet, and do you know Tom Seyfried? Maybe you don't, up in Boston. He has evidence from case studies, and then he's doing clinical trial of ketogenic diet. So is there anything known about, so for a long time I was thought that most tumor cells rely mostly on glucose as their energy source and aren't so good at using ketones, although that's not necessarily true. But so that the idea, and there are many clinical trials going on now, the idea is that you essentially, if you give a person chemotherapy or radiation therapy when they're fasting or some variation on fasting, it may be easier, number one, to kill the tumor cells, and number two, maybe to reduce the side effects, because the intermittent fasting actually activates cell protective mechanisms. So I guess, what about bioenergetics? How is it known how innervation, or if you have a tumor in the brain, the neuronal, well, it's kind of indirectly, you just said this, that activity, if there's more activity in the neurons, that means they're more energetically active, then that promotes tumor growth. But what about the energy source, glucose versus ketones? Is there any work on that?
I don't think so. At this stage, no, not that I know. So this is still an area to be explored.
Okay.
But you're right. It's probably connected too, because the activity of neurons is very dependent on glucose or other metabolic pathways. And so yes, absolutely. There is probably something around this, but this
Well,
still has to
the other thing that activity does in neurons, I mean, when people do functional MRI, right, to look at neural network activity, that's actually indirect. They're looking at blood flow. And there's a tight coupling of neural activity to blood flow. So more activity, more blood flow. So is there a contribution of increased blood flow to the cancer cells? In other words, kind of an indirect effect of neuronal innervation of the tumor mediated by, increased provision of nutrients to the cancers.
Yes, absolutely. So when the sympathetic nerves, I mean, liberate noradrenaline, first you have the volume of blood circulating, which is changed because of the diameter of those blood vessels changing in presence of noradrenaline. That's one mechanism.
Yeah.
But the other mechanism is that the new blood vessels will be created if you have sympathetic activation all the time. So angiogenesis is driven by sympathetic nerves in the tumor microenvironment. So yes, indeed, the activity of the neurons is going to have an impact on the blood flow in the organ and the blood flow in the tumor. Yeah.
Both acutely and then over time by increasing the angiogenesis, the growth of the blood vessels.
Absolutely.
Yeah.
So when you think about this system that you saw, I mean, which is the fight or flight system, also contributes to tumor development. So, it's important for our survival if it's transitory, probably. But if it stays around for a long time, if you have an hypersympathetic activation that stays around for a long time, it's probably not very good for cancer, because it does stimulate the growth of cancer cells, if there are any cancer cells around. plus angiogenesis, plus the metabolism of the organ. So yeah, there is a lot of repercussion to this.
Yeah. Okay. And let's see. Wow. Okay. So you kind of indirectly, yeah, you did stress, right? So there's evidence, well, chronic stress, you mentioned the immune system. Chronic stress can suppress the immune system through increased cortisol, hypothalamic, pituitary, adrenal steroids. And there's also evidence that chronic stress can impact, well, it impacts the outcomes of most diseases actually, but
Sure.
cancers too, right? But how do glucocorticoids have a direct effect on cancer cells?
Yeah, they are, but you know, it's a mix between direct effect and indirect effect. So I mean, to some extent, the impact of noradrenaline is more described than the impact of corticoids. And you know, the level of cortisol in the blood is changing all the time.
Yeah.
Difficult to trace. The level of noradrenaline, actually, you have almost no noradrenaline because it's in the tissues, not really in the blood. So because of all of this, the impact of stress in cancer has remained an area of controversy. It's, you know,
Okay.
there are animal experiments suggesting that, yes, if an animal has a tumor and you submit that animal to stress, then tumor growth will be accelerated. On tumor progression, there are animal experiments clearly showing that, yeah, stress is not good for tumor progression.
Okay.
But it's unclear for tumor initiation, in my opinion. So we have to be careful here. Stress might be a promoter of existing cancer, but not necessarily an inducer of. And all of this is very difficult to study and to, let's say, to clarify, because the mediators of stress are difficult to study in the blood. Cortisol in the blood, the level changes all the time. So what do you consider as the baseline? How do you associate? Plus the fact that stress is a subjective concept too. So you know, so all of this makes the connection between stress and cancer has remained an area of controversy. Having said this, the fact that the sympathetic nervous system, which is activated in stress and is part of the stress response, is a contributor to cancers, tends to say, well, there might be something more than we think here.
And there's good stress and bad stress, because as you know, and so caloric restriction or moderation in, you know, calorie intake, maybe intermittent fasting, exercise. During fasting and during exercise, that's actually a stress on the systems. But as long as there's a recovery period, feeding, resting, sleeping, then in the long run, you're actually better off, because we and other organisms evolved under conditions where the individuals who were successful in overcoming these fundamental stresses, you know, food scarcity is probably the major driver of evolution in general, brain evolution. So one thing we found, I had a graduate student, Jaewon Lee, got a PhD with me actually when I was at University of Kentucky, before I went to NIH. And he, there's a guy there, Jim Herman, who does a lot of work on stress, hypothalamic pituitary system and stress. And there's this paradox where if you put rats or mice on caloric restriction or every other day fasting, they live much longer. They have suppression of spontaneous and induced tumor growth. Okay, but they have elevated corticosterone levels, which is same as cortisol in humans in terms of what it does. So that was kind of a conundrum, you know, how is it? Because it seems like they're in a chronic stress state, but yet they're living much longer. So we did something very simple, and we're focused on the brain, of course. And it had been known that chronic uncontrollable psychosocial stress, for example, there's two receptors for cortisol. One's called the glucocorticoid receptor, GR. The other is called the mineralocorticoid receptor, MR. So bad stress will decrease MR levels and GR levels will remain high. But we found that every other day fasting, it's the opposite. MR stays high and GR goes down. So from that, our conclusion was that with these different kinds of stress, the way the cells respond to the stress hormone is different.
Yeah.
So that's, and that's one thing I think that's missed a lot in even endocrinologists, you know, that you see an elevation of whatever. So we know with insulin, right? We know about insulin resistance now. And people with diabetes often have elevated insulin levels because their cells aren't responding to insulin. People with obesity often have high levels of leptin because the neurons in their hypothalamus aren't responding to leptin. So just by measuring things in the blood, you really don't know what's going on actually in the cells, that
Absolutely.
the readout for the endpoint. So, yeah.
And the feedback loops in endocrinology for all the hormones are so important, and that does induce a lot of confusion.
Yeah.
Even among scientific studies and among scientists themselves.
Yeah.
There are a lot of things we don't understand now. And even only with what we understand, it is also sort of confusing sometimes. Yes,
Yeah.
absolutely. Yeah.
Yeah.
And you know, stress is like, you know, that reminds me when we were talking about too much of a good thing is a bad thing. So a little bit of stress is good, too much stress is, so
yeah.
Again, you know, then to design studies to investigate the role of stress in cancer, because of what you mentioned, is very difficult. And you end up with different sort of results depending on the type of stress you apply, the duration of that stress, etc.
Yeah. Yeah. Okay, let's see. So what are you doing right now? What kinds of studies are you doing in the laboratory? And are you involved in any yourself in either, well, somehow in some way with any clinical trials?
Yes, yes. So, you know, what we do is we try to clarify all the signaling pathways used by neurons in cancer. So it involves in vitro and in vivo animal studies. That's one side of the research going on in my laboratory. You know, the role of sympathetic nerves now is clearly defined. It's not exactly the same for sensory nerves. So sensory nerves, you know, one characteristic of sensory nerves is that they use a lot of different neurotransmitters.
Yeah.
There's a large panel of neurotransmitters in sensory nerves. So we try to define which one do what in cancer. That's one side of the activity. The other side of the activity is to repurpose neuropsychiatric drugs for cancer treatment, or other drugs that are already known to target neuronal pathways in cancer. And so, you know, the glutamate receptors, for instance, or they are promising therapeutic targets in cancer. And we already have drugs like for beta blockers or blocking antibodies against NGF, which have been used for the treatment of pain. They are in clinical use for the treatment of pain. All of this can be repurposed into the treatment of cancer. And we are involved in clinical trials also in this area. Yeah, that's what we do.
And what about GABA inhibitory neurotransmitter drugs that activate GABA receptors? Is that a valid approach or reasonable?
Yes, absolutely. Yeah. Absolutely. Particularly in brain cancer. This is what we are working on. Yeah, absolutely.
Yeah.
And you have old drugs like valproic acid or not drugs which were used in psychiatry that regulates those pathways, and they could be of use in cancer, and they have not been tested in cancer, most of them. So there is an entire new area to explore.
Yeah.
And what I like about this is also that the side effects are none. We know that those drugs have little side effects.
Yeah.
And this is nothing to compare with chemotherapy and radiotherapy, where you have massive side effects for patients. So if we could, I mean, maybe not replace existing treatments, but potentiate the activity of chemotherapy. Therefore,
Yeah.
we will, with those drugs, we will be able to use less drugs, less radiation, and have less side effect for patients. It means not only more effective treatments, but maybe also, hopefully, less toxic cancer treatments.
There's a lot of excitement about immunotherapies, stimulating the immune system to attack and remove the cancer cells. What's the role of now, for example, NGF? What are the effects of these neurotrophic factors consistent with enhancing immune surveillance of or removal, or maybe using, for example, NGF antibody in combination with an immunotherapy?
To my knowledge, nobody has reached that level yet.
Okay.
So we are not there yet.
Yeah.
Also because, those neurotrophic growth factors not only can regulate the immune response, but also they have an impact on inflammation.
Mm-hmm.
And inflammation is in a way a promoter of cancer as well. So, so there is this double situation with immune response on one side and inflammation on the other side, and the two can be regulated by neurons. Yeah. So what's exactly the balance between the two in cancer? That still needs to be clarified.
Yeah, and it's, I mentioned that once cells go into this senescence phenotype, they can't become cancerous, but then they start producing a lot of inflammatory molecules, and Judy Campisi did a lot of work on that over the years. Yeah, so it's complicated, and sounds like you're doing a good job of trying to dissect out the problem. You have a lot of questions to choose from, I guess.
Yes, yeah, absolutely. Well, that's the benefit of working on a new field or an emerging field, if you want. It's open.
And so are other faculty down there now? So where you're at now, is it mainly people in the cancer field?
Well, in the institute, at this stage, it's mainly in the cancer field. But what we start to see is that you have more neurobiologists now getting interested in cancer. Good. Yeah, so I think it's going to create a mass effect and, the snowball effect, I think. This is what we start to see. So there will be, in the coming years, more connection between neurobiology and oncology.
Yeah. Yeah, but, as we've kind of talked about back and forth throughout this conversation, the molecules that cancer cells and neurons respond to, and kind of what we call signal transduction pathways within the cells are similar. And myself, a lot of my focus is on how to keep nerve cells alive, right? And cancer researchers want to kill cancer cells, but we're studying the same pathways, and I'm trying to maybe increase growth factor level to keep the neuron alive. Yeah.
Absolutely.
But anyway, when you get down to the cells, most cells but there's more that's alike every cell, doesn't matter which one it is more like any other cell than unlike it, I guess is what you'd say, what I'd say.
Yeah.
Yeah.
And you know, there is a sort of a similarity, molecular similarity between cancer cells and neurons.
Yeah.
You know, they use the same neurotransmitters, they use the same molecules. They have sometimes, I'm even surprised, I cannot show you pictures here, but sometimes for some cell types, even in vitro in cell culture, you look under the microscope and you see, you know, extensions look like neurons, like neurites. You know, they are extensions for the cells to migrate.
Yeah.
But they really look like neurons. So there is a sort of similarity, not only molecular, but also a visual similarity between neurons and cancer cells.
And I don't know, you know, that there's a particular line or clone of cancer cells called PC12 cells,
Yeah.
pheochromocytoma. It was from adrenal, in the middle of the adrenal gland, the adrenal medulla. There's these chromaffin cells that produce adrenaline, epinephrine. And
yeah.
So these cells, you put them in culture without any growth factors, and they'll just divide like crazy and stay, you know, relatively round and so on. But if you add NGF, they'll start, you know, sprouting neurites. So I don't know.
They become real neurons.
Well, some people would argue
but
that, but they have a lot of neuronal properties. Yeah, that's true. Yeah.
Yeah, true, absolutely. And when you think about it, you know, in terms of embryology, they derive from the same layer of the embryo, neurons. And I mean, most cancer cells are epithelial in origin. And you know, most human cancers are carcinoma. They are cancer of epithelial cells. And epithelial cells and neuronal cells derive from neuroepithelial layer of the embryo. So there is a common embryologic origin of epithelial cells and neurons. And that probably participate to that similarity between the two cell types.
Yeah, very interesting. Okay, Hubert, thanks for your time.
Thank you, Mark. Thank you very much.
Yeah. Have a good rest of the winter down there.
Yeah. Today particularly is a very cold day, very windy, and we had something like 10 degrees this morning, which is very unusual around Sydney.
Yeah. Well, at least you're not burning up. So,
absolutely. All right.
Okay.
Thank you.
Bye.
Bye-bye.